Thank you. First of all, I would like to thank the organizing committee for inviting me for this important session and talk. And thanks, Dr. Kullar, for highlighting those slides. But I can, if you see some of his slides, so he had come to this thing. You see, last few slides, you will see that finally it came to that BK virus infection is more common in ABO-incompatible transplant rather than all other infections. So whenever we do, so the purpose is now, I know Dr. Khuller is one of the proponent of the ABO-incompatible transplant, and I know he does a lot of ABO-incompatible transplant, not less than any big center. But I'll just tell you what are the options for the patient who do not have a blood group compatible transplant. You have three options. Either you wait list for the deceased donor and you know what is the situation of the deceased donation in India. Second is going for kidney pair donation. You know, because of laws and all these, you have very few centers who are actually been able to do kidney pair donation. Even in Delhi and NCR, we are finding it difficult. So the other practical option you are left is only the ABO incompatible transplant, and that is the reality. Everyone should accept this and try to find a ways how we can make it less, more and more actually outcomes becomes better, and it is happening with the passage of time. So this is a study which has been published from South India quite some time back, that 45% of the donors were rejected because of ABO incompatibility. And we say because Japanese do about 30% of their transplant are ABO incompatible. So we find that one third of the patient, donors could be rejected because of the ABO incompatibility, which is a big chunk of the patients. So why ABO incompatible transplant? Obviously, because if you see all the data, ABO incompatible transplant, as you compared, even the HLA incompatible, you find that patient who remains on wait list or remains on dialysis, even the HLA incompatible has a higher long-term survival. And ABO incompatible, these are not the memory immunity which comes later on. This is a one-time thing, and most of the data you will see that the initial graft loss is higher, but the long term outcome does not differ much if you uh, pass initial hyperacute phase. And with the evolution of the desensitization protocol, so this is evolving now in India also. If you see in last 12 to 15 years, there has been a learning curve, and which is gradually the outcomes are becoming better and better. You know how much to desensitize. Previously, even after transplant, if there's a rise in titer, people used to do plasmapheresis, but nowadays very few people will do unless there is a clinical indication. So with experience you learn and your results get better and better. So there have been many reports and the studies which have shown there is an increased complication, mainly to infection and the bleeding after the transplant. And this is a study which I am quoting. Dr. Kuller has already shown this meta-analysis which has shown a higher risk of the infection. But as I shared, so this data has mostly derived from the registry and the cohort study. If you see the actual, there is no randomized trial, there are no prospective trial which have shown this. And disadvantage of these registries are quality of the data, completeness of the data, and inclusion of the patient who are treated with different desensitization protocols. So this is not a uniform thing. And recent study, I will not show studies with the very few patients. I will show only the big data. So this is a data from the Europe, which has been published 10 years back, 10 years of follow-up, and they have compared their 100 transplant ABO incompatible patient with uh, incompatible. As you can see in this study, there is a no difference in patient survival, death survival, graft loss, and serum creatinine at discharge and proteinuria. Coming to the infections, you can see the rates of the infection are 35 to 38%. There is no difference in any of those. So it is up to you which study you want to show and see. So there is things on the both sides of the story. This is a recent, again, data from 2022 from CIST cohort, transplant cohort. more than 600 ABO compatible versus 118 ABO incompatible, and you can see that the risk of the infections are not different and not higher. You can argue this is because they are mostly using the immunoabsorption based desensitization, which could be one of the factor versus the plasma exchange. And this is the data, the best data from the Japan for last 20 years, and which there are two sorts of periods. One is the 1989 to 2004, and another is after 2005 to 2013. So left is 89 to 2004. So there is an initial graft survival which was lower in ABO incompatible, and but later on this was not found to be significant. So patient survival was not different and absolutely same if you see the recent data. And the causes of the graft failure, if you see, the AMR was higher in the initial, but the later on the AMR was also not different, and the infection was not different. If you go to the various type of the infection, CMV infection and the adenovirus infection, these were the two infections which were more common in ABO incompatible transplant in the initial data, but in their subsequent data, and I am sure the result would only be get better with if they publish their data of the last decade. So, what are the factors which influence the higher infection rate? Because of we use induction agent, rituximab, desensitization protocol, center-specific prophylaxis. So, our aim should be that how if there is some infection, how can we reduce it? So theoretically, there is a higher risk of the infection with the add-on rituximab, and but the modern studies have not shown much difference with rituximab. This is a study in which they used rituximab as an induction agent after transplantation, a randomized double-blind study, and this has shown that there was comparable rates of the infection in high-risk patient and low risk of the rejection. So there was not much difference, but studies have shown like this. This is another study in which they have used rituximab for the induction ABO incompatible transplant, and they found that if you use the higher doses of the rituximab, this may be one of the factor for increased risk of infection in ABO incompatible transplant. But there was, and especially there was BK virus infection. So mostly the viral infection, especially the BK virus infection, is one which is slightly higher in those. Then you see there is a different sort of data. One meta-analysis showed no difference, and another meta-analysis showed that plasmapheresis as compared to immunoabsorption was associated with higher risk of the infection. Again, there is controversy. So what we can do, that prophylaxis to reduce the risk of the infection. Bacterial infection are mostly not high after ABO incompatible transplant. You can consider low dose IVIG after plasmapheresis to replenish the antibodies which are depleted. You can give CMV prophylaxis in some patients. And the more important which we should do is probably monitoring of the BK virus in these patients, and to adjust the immunosuppression, so this can be further reduced. So I will show my recent data, and I will the rates of the infection. So as Dr. Khulnar rightly pointed out, our overall infection is 38% in ABO compatible, and incompatible it is 44%. This is a median follow-up of actually, this is a data from 2012 when we started ABO incompatible transplant till 2023, 209 versus 2000 ABO compatible transplant. So after median follow-up of almost 60 months, the rates of the infection 38%. So infections are rates we have not they are there 40%, but in the both the group. And in this we have recently we analyzed that wound infection were higher, but all other infection in this latest data, they were not significantly different in our data at least. And this is a chart which shows. So you can say that there were numerically higher number of the infection, maybe UTI. Wound infection was only significantly different, but all other infection were not statistically significantly different. So we should accept the reality and move on how we can give more and more life to our patient. And ABO incompatible transplant is now widely accepted due to lack of deceased donation. I would be happy if I don't have to do the ABO incompatible, but this you can't go away with it, so you have to make it better. So you need to adjust the immunosuppression to minimize the infection risk. Balance is required, so that more monitoring is required. You need to optimize the prophylaxis, monitoring of the BK virus infection, and individualize the immunosuppression. And long-term survival is approaching that of the ABO compatible in recent studies, and it's a viable and safe option for expanding donor pool in a country like India, where deceased donor and the kidney pair donation are in the limited centers, and it's still a long way to go. Thank you.